Good day, everyone, and welcome to the International Medication Safety Network webinar, Medication Safety During the COVID-19 Pandemic, What Have We Learned in the United States? My name is Christina Mohalik. I'm a pharmacist and a medication safety specialist at ISMP, and I will serve as your webinar host. As the COVID-19 pandemic crossed the world, healthcare practitioners had to quickly adapt to rapid changing conditions. We saw, and in parts of the US, they continue to see, very sick patients presenting at an increasing rate. As part of our pandemic response, we not only needed to be nimble in our creation of treatment protocols, we also needed to quickly implement plans to use PPE to protect our practitioners, many of them who previously had not been regular users of PPE. Relatively early on, as the pandemic hit the United States, much of the in-hospital concern was related to supply issues. We heard and talked about PPE shortages. We have heard the worry related to ventilator shortages, and another big area of concern was drug shortages. A lot has been learned in the United States about medication safety compromises that were made during the COVID-19 pandemic. We're happy to say that our webinar today is supported by the Novartis Name Creation and Regulatory Strategy team, and we thank them for their support. We are delighted to have with us today our ISMP President, Michael Cohen, and ISMP's two international fellows, Nishta Shah and Allison Hansen. I'd like to introduce you to our speakers. Mike Cohen is the founder and president at ISMP. Dr. Cohen's passion for medication safety began in 1974 when he was involved in a serious adverse event with insulin in the hospital where he was employed. He immediately saw the value in sharing his story with other hospital pharmacists to prevent the same error from occurring. Dr. Cohen founded ISMP in 1994, and he is active in many patient safety initiatives, including, among many others, co-editor of the ISMP consumer website, chairperson of the International Medication Safety Network, and he currently serves as a consultant to the US FDA. Nishta Shah attended Temple University School of Pharmacy in Philadelphia, Pennsylvania, and after graduation, she pursued a PGY1 pharmacy practice residency at Nazareth Hospital. Being from India and going on a mission trip to Guatemala as a pharmacy student made her realize that on a global level, there is a need for standardization of medication safety to promote safe medical practice. Most recently, Nishta was selected as the 2020 recipient of the Temple University School of Pharmacy Alumni Association New Pharmacist Practitioner Award. Allison Hansen received her Doctor of Pharmacy degree from the Eugene Applebaum College of Pharmacy and Health Sciences at Wayne State University in Detroit, Michigan. During pharmacy school, Allison participated in the International Pharmaceutical Students Federation Student Exchange Program and Internship Program. After graduating, she completed a PGY1 pharmacy practice residency with Froedtert and the Medical College of Wisconsin, and that was followed by 4 years of clinical pharmacy practice. Allison hopes to blend her international interests with medication safety to pivot her career into best practices and policy work. Over the next hour, our speaker team will detail medication safety issues related to the care of COVID-19 patients in the US. Many of these have global significance. They endeavor to provide insight into the changes that were made and where we may go from here. I invite you all throughout the program to ask questions using the Q&A icon found at the bottom of your Zoom screen. I'd like to now hand over the virtual floor to Michael Cohen.
Thank you very much, Chris. Appreciate that. Yeah, this is, it's been an unusual situation for many of us around the world, and we sure learned a lot beginning in late February, beginning of March, when we started learning again and again about COVID-19 and the pandemic and how it was affecting hospital care in the United States. And, we talked about it recently and thought, boy, we certainly had a lot to learn during that period of time, and thought it would be great to share it with our international colleagues. And that's why we put this program together. We had done some talks here in the United States, and we got a lot of good questions about the material that we were presenting, and just thought we would duplicate what we did here in the U.S. to communicate a lot of the learning that we underwent. And I have to say, from the very beginning, a lot of what we were hearing was strange to us. We had never heard of this before. Probably the earliest, and if I may have the next slide, was a situation where we started hearing about infusion pumps set up outside of individual patient rooms in the intensive care unit. Now, I don't know if you've run across that situation in your hospital, wherever you are, whatever country you're in, but it was a very prevalent type of situation here. And I'll go into the reasons for that in just a minute. But you can see in this photo, for example, this is an ICU not too far from our headquarters in Pennsylvania, USA. You can see the infusion pump set up outside patient rooms all through the hallway there in this intensive care unit. And when we first heard about this, we thought, that has to be a mistake. Why would anybody put infusion pumps outside in the hallway? And look at all that you have to consider. Even on this slide, I've listed some of them. For example, in order to do this, obviously, if you're going to hang bags of high alert drugs for ICU patients, most of whom are in ventilators, outside the room, you need to be able to get the fluid to the patient, and that has to be done by using extension sets to the primary IV set. So we're going to be talking about that just for a little bit. And also, we had to consider what type of tubing would be used. With these extension sets, there's various inner diameters. There's macro bore, which obviously would probably hold the largest amount of fluid, all the way down to micro bore, which really limits the amount of fluid that would be in the tubing at any one time. And there's advantages and disadvantages of each. And I'll talk about that real quick. And pharmacists might have to be involved in some of the decision-making here, or certainly some of the acquisition, for example. So it is important that we all know about this. We also have these splitters in order to hang various drugs and be able to attach them to the single length of extension tubing that is going into the patient room and reaching the patient and being attached to the patient's IV. So we have certain connectors that are used for this that we had to become aware of. Also, labeling the tubing inside and outside of the room. Hopefully you have one single length of tubing, but there may be other infusions in the patient room. That's a possibility. And there may be more than one length of extension tubing is also a possibility, although usually it's just the one length of tubing that we've been made aware of, and multiple drugs infusing through that line. You had to be aware of compatibilities. You had to be aware of things like insulin, which adsorb to tubing. So obviously, when you have an entire length of tubing, and some of these extension sets are attached to one another. So an extension set of, say, 60 inches or 5 feet, that's the method of measurement that we use here. You might have 15 feet because you're attaching 3 different sets to get all the way to the patient. There's ways around that in some cases as well, and I'll mention that. And then, of course, if you're doing this, where does the tubing go? We started noticing that some of the hospitals would actually put the tubing underneath the door and secure the attachments and cover it with a pad so that if anybody accidentally stepped on it, it seemed very unsanitary, though. Obviously, that was a concern. So there are people that looked at other ways to get this into the patient's room. And then another issue is with COVID patients, we sometimes had rooms that were negative pressure rooms, so that any aerosolization of the virus would, remain in the room and be exhausted from the room and not get out into the patient hallway. In some cases, the whole nursing unit was negative pressure, and that had an effect as well. And we'll try to get to that. So very interesting situation. And, we weren't familiar with much of this at all. So again, a lot of learning. I don't know if you heard about this situation, but it certainly was happening, and it happened throughout the United States. And, right now, here we are in late June, and we're seeing increased numbers of patients as they are in other countries around the world. Some of us in the United States, some of the states, the number of cases are down significantly from where they were in March and April and into May. Yet, unfortunately, it's just the opposite for some of the other states in the United States. So we're very concerned today that we may have actually a growth in the total number of COVID patients. So this situation is not going away. It may still happen again, where we see, and is still happening, where we see infusion pumps outside the hallway. Next slide, please. The whole reason for doing this, by the way, you may have guessed, was to reduce nursing staff exposure. They didn't have to go into the room. With the pumps outside, the bag changes could be done outside. If there were pump alarms, that could be done without having to gown with PPE, personal protective equipment. So you could even conserve on the use of personal protective equipment. And early on, when we first started seeing large numbers of patients in the ICU on ventilators, we did have personal protective equipment shortages crop up in many hospitals around the country. They were reusing or not using it properly. And that was a major concern. So this was another impetus for keeping the pumps outside in the hallway, so the nurses didn't have to get into the patient room directly. Or perhaps one nurse was with the patient in the room, but the changes still took place outside the room, so someone didn't have to go in and out of the room to, access the bags and equipment, and make the changes at the bedside. So this did help tremendously to conserve on PPE. And then the other issue was, even nurses walking by in the hallway. It was much easier than going into the patient's room to respond to pump alarms. And as I said, the bag changes. So those were the major reasons for doing this, keeping pumps outside in the hallway. And we did a lot of conversation, a lot of communication with hospitals that were doing this. We talked to ICU nurses, we talked to pharmacists that were sometimes stationed in critical care, sometimes in the pharmacy, but were familiar with what was going on the nursing unit. And, they were telling us about this, and we learned an awful lot from them about how it was done. Next slide. So there were a lot of risks and challenges, as you might understand. One thing that happened early on, whoever knew that we would need so many extension sets in ICU? So perhaps, the materials management department had a supply to begin with, but as more and more patients came into ICU and more pumps were deployed outside of the unit, outside of the room, the shortage of extension sets became a problem. And in some cases, there was a shortage from the manufacturer, and they actually had to discontinue it and put the pumps back in the room. And then, unfortunately, it was going a little backwards for those that were keeping the pumps outside the room. Also, another thing that happened with the extension sets, the occlusion alarms. You're going at a very low flow rate. It might be delayed by the time the solution actually got to the point that it would cause an occlusion alarm. So those rates were very, very low, as you can see on the slide. And then more frequent alarms, if the set was, if the fluid was running at very large amounts per hour, like 300 milliliters and above. And so that was an issue as well. And you try to keep within those ranges. As far as flow rate accuracy, That happened due to downstream resistance with some of the pumps. So that had to be kept in mind as well. And, with the larger bore extension sets that were attached to the primary line, the infusion pump, there was more volume in the extension sets. So, a lot of the secondary infusions, like if you were running antibiotics or some other type of secondary infusion, it took a while for that to get to the patient, and some of that remained in the tubing for a long period of time. So it was important to know what type of tubing you were using and what the estimated volume might be. With micro bore tubing, the smallest with the inner diameter, it would be a few milliliters throughout the entire length. So you had a way of getting that to reach the patient a little bit quicker than using the large tubing. So you had to take that into account. And then the flushing procedures, obviously flushing from outside would be problematic as far as getting that flush solution through the IV access port. Next slide. There was also an impact on barcode scanning. In the United States, initially, one of the fellows from ISMP is going to be talking about this in just a minute, but we do have a large percentage of our patients where we have the barcode on every IV drug that's given, every IV bag, every IV syringe. We also have it on all oral unit doses, liquids, and oral solids. And so we scan at the bedside. We're up to over 90% of hospitals are scanning medications at the bedside in the inpatient area. Maybe not in some of the other areas like the perioperative area. One of the problems here was we weren't going into the room to change the bag. So what was done very frequently was a barcoded wristband was printed out and put on the pole where the IV bag was, the IV bag of fluid. And we use general purpose infusion pumps in the United States more than syringe pumps, sometimes syringe pumps, so the wristband would be printed there. And so that was out in the hallway, and it really isn't on the patient. And sometimes it's certainly possible that those pump poles or pumps could get switched around. So it wasn't something that was 100% accurate as a way to scan to assure that you had the right patient and the right patient's line. Some places didn't even use the barcode scan. They would just label the pumps with the patient name and date of birth. But by and large, we did come up with ways to use the patient's wristband. And at times, and there were many ICUs that had glass walls, for example, where you could have a nurse inside, scan the patient wristband, and then match that with a wristband printed outside by the nurse who's changing the bag. So you would assure, at least initially, that the right wristband was on the pole, and then that could be used subsequently, unless there was a change in the patient room or the pump and the pole. And then there were independent double check considerations. You need to trace the lines to make sure you have the right bag and the right line going into the extension set, or the splitter, which goes into the extension set to reach the patient. And, there were requirements to have, where you did have an independent double check, of having dual signatures for the electronic health record. And I mentioned the negative pressure rooms. We even had situations where maintenance would drill a hole through the drywall and then seal it off, except for the tubing going through the wall. And that was a way to keep the tubing off of the floor, which was something that would have been much better for many reasons. Even having that tubing on the floor became a tripping hazard. And we even had one report where a nurse did trip over that tubing. So that was something we really needed people to be paying attention to. And as far as the negative pressure rooming and negative pressure room and the tubing under the door, actually that really didn't have much effect on negating the positives about having a negative pressure room. We also had some where even the primary set, the patient bed would be moved right up against the wall. So, a very long primary set from the infusion pump could also be used directly, which was, that was a much more accurate way of doing it. And that happened in a few hospitals that we learned about as well. You had to make sure that you had enough power outlets in the hallway. Obviously, you can't run these pumps on batteries for all that long. So that was a problem. We didn't necessarily have it, or we used extension plugs, and that presented a tripping hazard as well. So the other thing we recommended as ISMP in our newsletters is we really thought that there shouldn't be 2 patient rooms in the ICU for, and use of the pumps out in the hallway. It should only be for situations where you had 1 patient in the room. And by and large in our ICUs, you have 1 patient in the room, but you didn't want a chance mixing up the tubing if you had more than 1 patient in the room, or if you were using this in a med-surg unit, for example. So that was part of it too. Next slide, please. And then, we did sometimes get to the point where we had such a surge of patients in the ICU, especially in certain states, that they began to run out of the, not just the extension sets, but administration sets and even pumps. And so that was something that we looked into and talked to a lot of hospitals about how to overcome that. And they developed a list of medications that absolutely had to be infused through a smart pump. You may have guessed that this is the list that we refer to as our high alert drugs. And I mentioned some of them, but every hospital had to come up with their own list. These were just suggestions that we had. That way, drugs that weren't absolutely required to be given by pump, it could help to save some of the infusion pump use just for these high alert drugs. And we did use some syringe pumps, even though some nurses may not have been familiar with them at first. They had to get familiar with them. Another situation that we ran into was we had personnel shortages, and we would have nurses from the perioperative area or even other areas of the hospital that would come to the ICU, and they weren't necessarily familiar with all the equipment that was used there, the barcode systems, the independent double check systems. So that was affected as well. We couldn't always do all that we did previously. So the other thing was sometimes hospitals have infusion pumps that aren't generally used, or the older ones that haven't been discarded or returned, and they needed to be recalibrated by the biometric department at the hospital, but some were going to those as well. And then even consideration for accessing pumps from a rental agency or from other manufacturers. I don't know many hospitals did that. It wasn't something that we promoted, but when you were down to no pumps at all, you had to take unusual measures. And then of course, there are always infusion pumps if you hunt for them. In radiology, in the cardiac cath lab, in other areas of the hospital, locked in closets, who knows? So some hospitals were able to find pumps in those areas. Next slide. And on this slide, we also talked about switching patients from IV to oral as soon as possible as a way to conserve on pump use, giving oral rather than IV hydration whenever possible. There was no reason to use IV hydration and take up a pump, then give it by mouth wherever possible. Changes in IV set policy, IV set change policies was important. Some hospitals use the Infusion Nurse Society standard of 96 hours. Others went to our CDC, a government agency here in the United States, which gives up to 7 days for an infusion set. So that was used. And then IV push medication administration. We have guidelines on our website. You'll find them very easily. And I would absolutely recommend that you take a look at them. We promoted their use during the COVID-19 and even today, obviously. So we ask that people review the safe practice guidelines. They cover a lot of really important information about labeling and clinician preparation and our reporting and on and on and on, diluting, so on and so forth. So we promoted that. And then, we asked for pharmacists to put the flow rates on labels, giving so many milligrams over so many minutes. Obviously, the concentration should be on the syringe as well. And also in the medication administration record, we often print that out, or it's available electronically for nurses to use. And that information should be there too. We really promoted the idea. We use a lot of manufacturer pre-filled syringes that are in the exact dose that you need. So ready to administer infusions or syringes is something that we promoted, rather than diluting medications in a syringe or giving them through an IV pump like a syringe pump. And then also finally considering issues when giving IV injections via the Y site, inadvertently bolusing drugs into the extension set, which takes a long time to get to the patient, would be one of those problems. And next slide, please. We also talked about going back to gravity infusion, which many of us, that have been around for a while would be familiar with. We had to go to drop counting in some cases, but that was done. There are some calibrated IV flow rate regulators that were acquired. These are dial-a-flows, for example, is one brand name where you dial in the rate. It's not necessarily more accurate, but it's easier to set up. You still have to count drops. And then we have other devices like elastomeric infusion devices, where you can put a certain volume of drug in the elastomeric device, and that infuses into the patient. And that burette tubing was another way to get a little bit closer to accuracy without using infusion pumps. Next slide. We also looked at a process called hypodermoclysis. Some of you may be familiar with that, where you infuse a drug subcutaneously. Sometimes we use a drug called high hyaluronidase to break down the cell wall and make that go a little bit easier. I'm not sure how many hospitals went back to that. This is pretty common for use in long-term care facilities. I shouldn't say it's common, but long-term care is familiar with this, mostly for hydration, but it is okay to give some electrolytes through this type of process as well. And I outline on the slides ways that that could be done. And again, there are some standards for doing this that are available through the Infusion Nurse Society. Next slide. And finally, I'm going to turn this over to Nista, who will continue. Nista?
Thank you, Mike. So continuing to share our learnings, in March, we received a report regarding a patient who suffered cardiac arrest due to QTc prolongation as a result of using hydroxychloroquine right after discontinuing azithromycin. Next slide. Patient was initially treated for community-acquired pneumonia with oral azithromycin, the 500 milligram on day 1, followed by the 250 milligram daily for 4 days, along with ceftriaxone. She was later tested for COVID-19 and confirmed to be positive. 1 day after azithromycin was discontinued, the patient was started on the oral hydroxychloroquine because of the COVID positive test. On admission, patient's ECG showed QTc interval of 460, and the day oral hydroxychloroquine was started, the patient's ECG was 490. And 3 days later, the QTc was 515. No actions were taken as a result of this prolongation on day 3. And as a result of which, the 5th day, the patient experienced the ventricular fibrillation, or the VFib, and coded due to the QTc prolongation. Next slide. I understand that in this time of uncertainty of what works and what doesn't work, practitioners are getting impatient and using anything and everything that can help them save their patients. But while doing so, it is important to remember the basic pharmacology and safety profiles of these medications so that we don't harm our patients. It is vital to monitor the QTc prolongation with certain medication, especially when the patient is at predisposed risk, which in this case, the patient was elderly and a female. Hydroxychloroquine have half-life of up to 40 days, and azithromycin's half-life is up to 72 hours. Therefore, even if these medications are not initiated at the same time, knowing the last time the patient was exposed to either medication becomes vital to ensure the safety of the patient. Discontinuing one medication and starting another right away might be life-saving in some situations, but then monitoring and acting accordingly is important to avoid adverse outcome. Now, it is important to remember that this error was reported in March when the use of hydroxychloroquine was at its peak due to presumed utility of this drug for COVID patients. But just recently, the US Food and Drug Administration, which is the FDA, revoked the emergency use authorization that allowed for chloroquine phosphate and the hydroxychloroquine sulfate donated to the Strategic National Stockpile to be used to treat certain hospitalized patients with COVID. So the FDA determined that chloroquine and hydroxychloroquine are unlikely to be effective in treating COVID-19 for the authorized uses in the EUA or the emergency use authorization. Additionally, in the light of ongoing serious cardiac adverse events and the other potential serious side effects, the known and the potential benefits of chloroquine and hydroxychloroquine are no longer outweigh the known and the potential risk of the authorized use. So the recent results from a large randomized clinical trial in hospitalized patients, a population similar to the population for which hydroxychloroquine were authorized for the emergency use, demonstrated that hydroxychloroquine showed no benefit on the mortality or in speedy recovery. This outcome was consistent with the other new data, including the data showing that the suggested dosing regimens for chloroquine and hydroxychloroquine are unlikely to kill or inhibit the virus that causes the COVID-19. So in totality of the scientific evidence currently available indicate a lack of benefit. Next slide. But while doing so, it is important to remember that basic pharmacology and the safety profile of these medications so that we don't harm our patients. Another important safety topic during COVID was the utility of the independent double check. The manual independent double checks of certain high alert medications have been widely promoted in healthcare to help detect potentially harmful errors before they reach the patients. And despite all this positive attitude towards the independent double check, manual independent double check have long been disputed and even discounted, and even sometimes misused in our healthcare. Many have complained that the process is time-consuming and often associated with practical problems in carrying them out, such as the staffing shortages and disruptions in workflow. And as you know, during COVID, an additional factor contributing to the list of shortcomings was the shortages of the personal protective equipment, or the PPEs. Next slide, please. In a need to conserve PPEs, facilities have considered suspending and or even modifying their independent double checks at the bedside prior to administration of the high alert medications, specifically to the COVID-19 positive or presumptive positive patients. Altering the independent double check procedure and documentation process can compromise the patient's safety, as it can lead to an unsafe practice habits in future. So once we are past the pandemic, some staff members might continue their process of not really using or utilizing the independent double check to its fullest. Thus, the hard stop in the electronic health record system requiring the dual documentation of verification before proceeding now reflects only the component of the check that can be accomplished outside of the patient's room. So, for example, in a hospital where the infusion pumps remain in the patient's room, the nurse who enters the room takes a picture of the pump screen using a mobile phone device left in the room, and sends that picture to a nurse outside the room via a secure messaging system. So how this helps is that it allows most of the requirements of the double check list to be verified without the second nurse entering the patient's room, and thus saving the PPE and the exposure to the COVID positive patient. Next slide, please. So independent double checks should be used judicially for only the most at-risk high alert medications, not for all high alert medications. ISMP have always recommend that before starting to use the double check method or independent double check method, first evaluate your requirements for independent double checks to see if you can narrow their use to just a few of those most vulnerable high alert medications. Fewer independent double checks strategically placed at the most at-risk points of medication use process will be the most effective. For example, one hospital reported that the independent double check for the subcutaneous insulin have been suspended for all except the U500 insulin. So in United States, I'm sure not all the countries use the U500 insulin, but in the United States, we use the U500 insulin, which are at very high risk of making an error. So this hospital only had the independent double check for those U500 insulin. And the dual sign-off in the EHR for the subcutaneous insulin has been disabled for all the other kinds of insulin, just so that the focus can be on the U500. For any independent double check suspended during pandemic, ensure that you are also using some other high leverage strategies. For example, the use of barriers, the computer alerts with hard stops, or standardization, the barcode scanning, just so that you can prevent some potential errors. Keep in mind that the video conferencing example that I mentioned earlier may allow the independent double checks to be conducted virtually, particularly in the pharmacy as well. So for example, that a pharmacist verifying orders at home and a pharmacist working at the hospital may be able to independent double check for each other. So the video conferencing or the use of the digital images in intravenous or the IV workflow system may also be useful for the pharmacy technicians during the store preparation. If this technology reduces the number of people in the clean room, it will also reduce the need of the PPE. Though we would recommend that before initiating any kind of video conferencing or any virtual device, check with your information technology or your IT staff to see if your organization requires a secure system for such activities. Next slide, please. Another important risk reduction strategy that Mike mentioned earlier is to engage the barcode scanning at bedside. So in early May, we received a report where a hospital noticed a trend in errors where failure to engage barcode medication administration at bedside led to some undetected errors. Next slide. Hospital noticed that due to the COVID-19 related staff changes, such as the operating room nurses who might not be familiar with the technology or the process or the medications used in the intensive care units or any other medical search floors, have been administering medication without using the barcode scanning at the bedside. So the error that shed light on this issue was where the OR nurse or the operating room nurse administered an albuterol inhaler instead of the fluticasone vilanterol, which the brand name is the Brio Ellipta, which was originally prescribed for the patient. No harm reached the patient, but this was just one of the many errors that was noticed due to bypassing the bedside barcode scanning. So, and such errors are not just with COVID-related patients, but are something to look out for even after the pandemic, when the staff gets redeployed and them not being familiar with the technology. Next slide. The hospital realized that dispatching staff from their usual units or floors to other areas can potentially cause some errors due to an unfamiliarity of the technology or the medications or the policies and procedures pertaining to the specific patient care unit. So it's very important to have an in-depth orientation explaining the expectations and the requirements for safe medication use process whenever the patient or whenever the staff is redeployed to a new floor. Next slide, please. During coronavirus or the COVID-19 pandemic, healthcare workers have often placed the needs of their own above the others, right? Or rather, sorry, needs of others above their own. Yet they themselves face unimaginable anxiety and stress and depression caused by the burden of such a profound illness and a prolonged pandemic response. Leaders need to support their healthcare workers through this chaos. The trauma of caring for patients with COVID-19 could affect more people than those seriously ill from the infectious disease itself. Next slide, please. More than half of these healthcare workers reported contact with a COVID-19 patient only in a healthcare setting. With a median age of 42 years, about 10% of the healthcare workers have been hospitalized and 27 have died across all age groups. Now, again, this data was from March through April. So the number of infected healthcare workers is likely underestimated since most reports of confirmed cases do not include whether the person worked in healthcare or not. Some healthcare workers have watched their colleagues become sick with virus, and then yet they still have to come back to work with all their anxieties and stress that I might get infected. A recent online Gallup panel survey conducted between March 13 and April 14 revealed some troubling findings. Only about half of the healthcare workers strongly agreed that their employer has communicated a clear plan of action for COVID-19. And nearly 1 in 5 feel their employer has communicated too little about COVID-19. Furthermore, only 1 in 3 are confident that they will be safe if they follow their organization's policies during the public health crisis. Now, this survey's results are a little bit troubling to me, as they clearly show that the healthcare staff do not feel well informed and well resourced. Next slide, please. So first and foremost, healthcare workers need to know that hospital leaders have their back. Leaders do not need to have all the answers or have to immediately solve all the complex problems associated with pandemic. However, they do need to be effective listeners and have transparent communication. During a webinar sponsored by TMIT Global, it described the specific areas of leadership support to urgently safeguard the healthcare workers' physical and emotional needs. So I've highlighted the main concepts here. First one is creating safe haven. Leaders need to create a safe and a quiet place for your healthcare workers, so they can retreat and talk to each other away from the busy work areas. A place where they can reflect, meditate, laugh, cry, or even take a quick nap. In safe haven, workers should be encouraged to keep in touch with their family, whether it would be through social media or just being in contact with them. Second one is restore fair and adjust compassion. In the face of daily pain and suffering, it is very easy for staff to feel burned out. Even without a pandemic, sometimes staff feel burned out. So you can imagine what effect the pandemic can have. Or to blame themselves for less than ideal outcomes. They may feel that they have failed a patient or second-guess their clinical skills. So leaders need to guard against this by encouraging workers to feel compassion for self and the others. And to rebuild the compassion for ourselves is the most important concept for being a fair and a just compassion. Third is establish a positive mindset. So positive emotions improve not just your emotional health, but also your physical health. Foster trust and compassion, buffer against depression, help people recover from stress, and build resourcefulness. For example, leadership information sharing with healthcare workers typically occurs daily in your huddles or the meetings that you have, where you communicate the rapid and evolving changes in the policies, the procedures. You might share the number of COVID cases in your hospital or the deaths of COVID patients, or on what's going on in the world, the numbers changing in the world. But the news about the revised policies and procedures and special guidance for the specific department should be balanced with a specific acknowledgement and sincere appreciation of your staff. Leaders should remind workers of what they loved about their job before the pandemic came along. And consistently ask your staff which aspects of their current situation they might consider a gift to be cherished. Fourth is, as I mentioned earlier, communicate transparently. Transparent communication is a one leadership behavior that is extremely important because it will create an environment of the trust and loyalty. and it will avoid the secrets and surprises, and will create some realistic expectation for a follow-up about such concerns. Fifth is to be a visible leader. Nothing does more to engage and inspire your staff than just being there. Leaders should not play it safe and just stay in their office so they cannot be questioned. Instead, they should invite questions and concerns. Take the time to appreciate meaningful work and to recognize and thank your staff. That will definitely go a long way. Provide opportunities for connectedness. So, in this day and age of isolation and being away from your loved ones, leaders should strive to build that community among your staff and encouraging the social relationship. And COVID-19, as I said, has caused a collective trauma with all this isolation from your family and friends. So leaders should definitely arrange some occasional meal together or gathering in small groups for your workers in a safe haven. And the last one is encourage self-care. So leaders should encourage some habits and attitudes that promote physical and psychological wellness. Not just with the movement or with the sleep, but also with meditation, the sunlight, and a healthy diet. Leaders should also encourage constructive attitudes in your staff that promote well-being, such as gratitude, kindness, forgiveness, and just caring for each other, just being thankful for each day that we're at work. So in summary, healthcare leaders have a significant role to play in this world that will be forever changed after this pandemic. Because this pandemic has brought about many unprecedented mental health concerns, leaders must continually build support system for their workers to hold on to both during and after each wave of the storm. Now with that, I would like to hand it over to Allison. Next slide.
Thank you, Nishta. Hello, everyone. Today, one of the topics I will cover is revisiting the need for metered-dose inhaler common canister protocols. Next slide, please. Patients infected with the coronavirus often require bronchodilator medicines. Nebulizer therapy with bronchodilators may not be safe due to the generation of aerosols. Aerosols can increase the risk that respiratory droplets will remain in the air. For COVID-19 patients, this means droplets containing COVID-19 may remain in the air and can be spread to healthcare providers. Thus, delivery of these medicines via metered dose inhalers, or MDIs, is preferred over nebulizer therapy. In the United States, as a result of increased use, there have been concerns about inhaler drug shortages. We experienced supply chain disruptions, which left some hospitals with just a few days' supply. As of yesterday, June 22nd, 2020, in the United States, some generic albuterol metered dose inhalers still remain on shortage. Next slide, please. As a result of shortages, hospitals in the United States have come up with creative solutions to address these challenges. MDI canisters typically contain enough medicine to last 2 to 4 weeks, while patients are often hospitalized for shorter periods of time, which can lead to drug waste. One of these solutions is the creation of a common canister or canister reassignment protocol, where multi-dose, metered dose inhalers are segregated and cleaned for future patient use by another patient. So let me reiterate that. So an inhaler that was used in the hospital by one patient is cleaned and saved and then given to another patient when they're readmitted. An example protocol can be found in our ISMP newsletter linked on the MDI title slide of this presentation. We encourage organizations to carefully analyze common canister or canister reassignment processes to prevent inadvertent sources of transmission and emphasize complete disinfection. We ask that organizations consider excluding patients with presumptive or confirmed COVID-19 infection. In addition, ISMP has asked manufacturers to provide smaller containers of MDIs to prevent unnecessary waste and lower costs. Another idea to circumvent metered dose inhaler shortages is to ask patients to bring in their own inhalers and take the inhalers home upon discharge from the hospital. So these would be inhalers that patients received from a community or retail pharmacy. And then when the patient goes into the hospital, they would bring that with them. And when they leave the hospital, they would take it with them. Next slide, please. Our next topic is pharmacist order verification tips. Next slide, please. In the United States, pharmacists verify all medication orders after a medication is prescribed. This occurs in the hospital as well. Verification is a multi-step process in which the pharmacist evaluates the medication order or prescription for safety, efficacy, and appropriateness by examining drug and patient-related factors. After the order is reviewed and is deemed appropriate, the medication is dispensed by the pharmacist. During the COVID-19 pandemic in the United States, hospitals identified the need to decrease staff exposure to COVID-19 patients and conserve personal protective equipment, or PPE. One of the ways to reduce exposure was to reduce the frequency of hospital staff entering patient rooms. This was reiterated by Mike and Nishta earlier as well. Pharmacists determined changes in medication orders or prescriptions could help reduce the frequency of hospital staff entering patient rooms. Also specific to the United States, many hospitals moved a portion of their pharmacist staff off-site with the intention of decreasing the risk of staff exposure in common areas as well as patient care areas. Pharmacist staff were given special software, typically via virtual private networks or VPNs, to securely access the hospital's software at home and process those medication orders from their homes. This decreased the risk of spread of COVID-19 through pharmacy staff, but introduced new potential risks, such as distractions while working from home, perhaps slow internet, and challenges for communication with hospital staff still located in the hospital, communicating with the pharmacist at home. Next slide, please. Some examples of pharmacist order verification tips are listed on this slide. During the COVID-19 pandemic, it became crucial to change some medications from intravenous infusion administration to oral administration or intramuscular or subcutaneous injections, or even intravenous push. These changes help conserve tubing, as Mike mentioned, and intravenous pumps for more critical patients, and also decrease the frequency for staff to enter the patient room. In addition, pharmacists bundled administration times. For example, some medications can be dosed multiple times a day or once daily. Pharmacists in the United States work hard to adjust medication times and decrease the frequency of medication administration or group medications together, thus decreasing the amount of times the nurse may need to enter the patient room in order to give the patient his or her medication. Pharmacists also made sure patients receiving bronchodilators actively needed them, thus conserving supplies. Lastly, in the United States, pharmacists are key in building software to facilitate accurate medication prescribing in electronic health records and computerized physician order entry systems. During COVID-19, pharmacists were instrumental in keeping up with clinical recommendations and making sure those changes and recommendations were reflected quickly and accurately in software systems. Next slide, please. Our next topic is remdesivir drug labeling confusion. Next slide, please. In April, ISMP received a report about a hospital compounding issue due in part to label confusion with remdesivir. The hospital had implemented an investigational study using intravenous doses of remdesivir to treat patients with severe COVID-19. In the United States, some hospitals have received remdesivir manufactured by Gilead Sciences under a compassionate use program or through clinical trials, or now through an emergency use authorization program issued by the U.S. Food and Drug Administration. The area in question is related to investigational use for a clinical trial. Next slide, please. The adult clinical trial protocol at this particular hospital called for an initial loading dose of 200 milligrams, followed by subsequent 100 milligram doses. The pharmacy technician inadvertently used 2 vials to prepare each subsequent remdesivir dose, exactly as he had done just minutes before when prepping several loading doses. The pharmacist failed to catch the error during the checking process. And unfortunately, the investigational medicine did not have a barcode from the company or a barcode applied by the pharmacy. The 200 milligram doses labeled as 100 milligram doses, thus, unfortunately, were administered to multiple patients that day at that particular hospital until the error was caught. Next slide, please. ISMP has long known that investigational drug labeling is subpar because it does not adhere to the rigorous standards set for FDA-approved medications. Here on this slide, we have 2 examples of poor labeling. The first group is the emergency use authorization labeling at the top of the slide. The label on the top left, liquid, has on the carton and label 100 milligrams per 20 ml or 5 milligrams per 1 ml. The label on the top right there, lyophilized, has on the carton and label 100 milligrams per vial. So there's a huge difference there between the liquid and the lyophilized. On the right, it would have been better to see the format of the label similar to that on the left. So what we like to see at ISMP and what we have in our United States Pharmacopeia regulations for FDA-approved medications is we like to see the total drug per total volume and then the drug per 1 ml. So both formats there. Also, you may note for those emergency use authorization products is that the liquid and lyophilized drugs have different instructions for reconstitution and or dilution. In the second group, so the labels at the bottom of the slide, this is for clinical trials. The clinical trials were started before the FDA's emergency use authorization. Here for the clinical trials on the bottom left, all we can see is 5 milligrams per ml. We don't see the total drug per the full container. That's a problem as well, and that contributed to the error that we saw on the previous slide. And then on the bottom right, we see that it says remdesivir 100 milligrams, but again, we don't really have any information once that's diluted what the volume would be, so that's a problem as well. So if a hospital is involved in a clinical trial and receiving product from the emergency use authorization, this can get very confusing. As said before, investigational drug labeling is typically poor because it does not adhere to the same standards set for the US FDA-approved medications. And ISMP has asked FDA in the past to make changes. Next slide, please. In the meantime, it's important for hospitals that are ordering these medications to implement safe practices. To prevent errors, consider adding a printed barcode label to each remdesivir container so barcode scanning can be used for compounding and dose verification. Pharmacies may also want to consider affixing an auxiliary label to the remdesivir vials to note the total amount of drug contained if it is not clear from the vial label. We also suggest providing prescribers, pharmacy staff, and nurses with a fact sheet or pharmacy guide or the US FDA emergency use authorization information. And now I will hand the presentation over to Mike Cohen, who will speak to you again about some more recent ISMP concerns.
Mike, we can't hear you.
Sorry about that. I forgot to unmute myself. Thanks for reminding me. I just wanted to get one more thing in for the talk today. You know, we sometimes run into these drug shortage situations, and obviously with COVID-19, we've used a lot of critical care drugs. We have a lot of patients that really have exhausted the supply of things like propofol in larger containers that are used for infusion as sedatives with patients that are intubated. And we also have similar situations with problems keeping up with the supply of neuromuscular blockers, paralyzing agents. In particular, we use a lot of becuronium and rocuronium. And this slide depicts a couple of the issues that we've had. We sometimes, and I'm sure this happens in other countries as well, import drugs from other countries or have drugs come into the United States that are manufactured in other countries. And that is exactly what's happened here. So we had a couple of situations that were very unusual. We use a lot of propofol in 100 milliliter containers in the ICU for patients on a ventilator. And we have always used a 1% emulsion of propofol. The most popular brand name is Diprivan in the United States. And as you may have guessed, we began to run short on that. And one of the manufacturers, Fresenius Kabi, has a 100 milliliter container of 2%. So we began to import that just this past week. We had been planning for it, and we had a notice in our newsletter. And the company is providing stickers to come along, to go along with the drug in the packaging. And basically, the concern here is if people aren't aware of one being 2%, the other one that we're used to being 1%, obviously the rates of flow are much different. You can get more time out of a 100 milliliter 2% than you can a 1% while giving the same amount of drug per minute. But at any rate, the 100 milliliter 2% has just reached the United States within the past week or so. And we have, alerted the field through our newsletters and so on, and also work with the, in the United States, the Anesthesia Patient Safety Foundation, so that all the anesthesiologists are aware of it too. Even though it's used in the ICU, we think some of this is going to travel to other areas of the hospital, and it's important for everyone to know 2% versus 1%. And with the neuromuscular blockers here in the United States, we have a warning on the caps or the ferrules, the metal band that holds the rubber stopper on the drug vial. And the warning says, warning, paralyzing agent, or some of them just say paralyzing agent. All neuromuscular blockers have that wording. We just recently had a situation where, actually it hasn't happened yet, but it's about to occur, where we're going to be importing drugs that are manufactured outside the United States, and they weren't able to get the normal caps that we use here that have the warning text on it. So they're going to come through, as you see here on the slide on the bottom there, without the warning. And the concern there is not so much that, the warning statement is missing, as much as it makes the cap look like a drug of the same size vial, which might also have a gray cap like this, look the same. And we're very concerned, obviously, that if somebody's looking down and this drug is standing up in a bin that's below eye level or on a shelf that's below eye level, you can see where they might confuse that with another drug vial, especially one of the same size. So we've been able to send warnings out like that. And we love to learn about these things going on in other countries as well. But I did want to mention that to you. It's part of the learning here in the United States. We pay a lot of attention, obviously, to drug shortages at ISMP. And, we alert the field when we learn about things like this. We get great cooperation from our Food and Drug Administration and also from the manufacturers before we're able to publish things like this. But I did want to show it. Thank you. And Chris?
Thank you, Mike. Since we're over on our time, I would just like to thank again the Novartis name creation and regulatory strategy team for their support of this ISMP webinar. And I would like to thank our speakers for their insightful message on the lessons learned about medication safety compromises made during the COVID-19 pandemic in the US. Thank you all for attending, and we hope you have a wonderful week.